Good afternoon once again. I'm Dr Ajirotutu, a member of the psychosocial response team. Well, we have our work set out for us and what we have been doing since this team has been working with COVID patients. One, we do disclosure of cases to positive cases. We also handle the inpatients. We prepare some of those patients for discharge, and also we render follow-up services. But one key area which we tend to start is to take into consideration the psychological state and also provide support for frontline health workers. These frontline health workers are people working directly with these patients on the wards. And from what we are even seeing, some of them have also been affected and are presently receiving treatment. And definitely this would affect the psyche of the ones working, because some of them are their colleagues. And what do you expect? Anxiety, fears, and worries will set in. And those are some of the things that has been going on there. So we've been directed to see how we can render psychological services to be able to help these individuals. Everybody will not be at the front line, and for officers at the front line, we need to buffer or help by supporting them emotionally. So our pillar, the psychosocial team, has been given that responsibility to do that. So what are we going to be doing? We are going to be looking at ways of working with them. Well, we talk about debriefing and desensitization for health workers. Well, the word debriefing is, what comes to your mind is, oh, debriefing after the incident, after the event. That is when debriefing will take place. Yes, but right now, we don't need to wait till after everything is over because of the experiences these people are going through, both emotionally, physically, and even cognitively. So we are going to be seeing them on a regular basis every fortnight, and we are covering 3 areas. We'll be covering IDH, mainland hospital, we'll be covering LUS, and also the only call center where patients are admitted. Like I said, how do we define debrief? What is debriefing? It's a specific technique designed to assist others in dealing with their physical or psychological symptoms that are generally associated with traumatic exposure. Because they are exposed to people going through it, that's enough effect to develop anxiety and worries and fear. So how does this work? It's a structured directive intervention which has an agenda and professional procedures which we are going to go through. And it aims to normalize their reactions, give them, educate them about coping skills, and offer guidance on warning signs to deal with these issues. And before you talk about debriefing, diffusing could come up. It's done on the day of the incident and designed to ensure understanding of reactions and to discuss resources for the other services. Because of what we are dealing with, we don't have the ample time. So we might have to modify the procedures to be able to deal with the present situation at hand. And so we'll be moving ahead to look at what this entails. It entails certain steps. But before I go to that, I just want, because we have a team on ground already, we are 3 of us in that team, and eventually we might need to draft 1 or 2 more people. So I just want to give an overview of certain things before going into the main procedures. Hope I'm online. Hello?
You're online.
Hello?
You're online. You're online.
Okay. So we look at what is the reason for this. Why do we need to debrief? Well, to help these health workers start with early intervention, to deal with their traumatic memories, opportunity for them to ventilate emotions, which might help them reduce their psychological state, opportunity to verbalize the trauma, which comes in the form of fears, worries, regrets, and we put them through a channel which will be able to help them, relieve their emotional state. Then to be in form of group therapy, we'll be doing group therapy for them. We're not going to do individual, but when we do group therapy and we're able to identify some of them who would need one-on-one, we can apply that form as well. So group support also would be a factor for them, and also room for follow-up. So for the debriefing team, there are 3 roles: the team lead, the team co-lead, and also the doorkeeper. The team lead must be a professional in mental health, and there are specific things which the team lead has to do. Because of his or her wealth of experience, you have to be able to encourage participants, you have to be able to make clarification, and you should be able to make summaries, to summarize issues which are discussed, to maintain orderliness, the ability to assess psychological well-being, and also instill positive outlook. You should be able to teach and also arrange appropriately for follow-up. That is expected from the team lead. While the co-leader also shares same leadership roles, but plays a significant role in arranging follow-ups and contact. While the doorkeeper would not allow people who are unauthorized to be part of it, and also encourage people to attend the debriefing and not to have a break-off from the debriefing. So what are the goals of the debriefing? What are the goals? 1, to provide reassurance, to facilitate speedier recovery for these individuals who are experiencing this, and also to provide information about their experiences, their reactions, and also management techniques, and to provide a sense of post-crisis psychological closure, if possible, because we always talk about closure. After going through this, you walk them towards closure at the end. Then there are certain rules which guide this with debriefing. No authorized persons are allowed to attend the debriefing. Confidentiality is paramount. Participants should only speak for themselves, and you encourage everybody to participate. You must not be judgmental, you must also not be critical. You don't criticize participants. Then also make sure that things that would distract are not available, like phone calls and other things which would distract people during the session. Then and during the meetings, during the session, there's no hierarchy. Participants have no rank. Everybody is equal because they're all going through the same experiences. So in preparation for the briefing, the team must arrive at the venue ahead of time before schedule, like an hour before the schedule, to make sure the place is conducive for. And it must be done away from the treatment centers. I don't know how we are going to work around that, but I'm sure we'll still look into that, how we're going to be quite away from the treatment centers. Then also we familiarize ourselves with information about the event. We should have certain key information which we are going to work with. Not that you will now be discussing with them, you have no information about what they are even going through. We are talking about ability to empathize there also. Put yourself in their shoes to see things from the right perspective. Then also the team must have met a couple of times privately to discuss their approach on how to go about the debriefing. And there are specific roles to be assigned to each person. Like the roles I mentioned earlier, the team lead, the co-lead, and also the doorkeeper. So they have specific formats which is followed in the briefing. And this is Mitchell's model of the briefing. It's a 7-stage intervention with the following stages. 1, introduction. We're now going into the phases of the briefing now. Introduction. 2, facts. 3, thoughts. Number 4, reaction. Number 5 talks about symptoms. 6 talks about teaching. And also re-entry. So I'll run through these 7 phases or stages quickly because we are working with time to be able to tell. They will modify as we go on when we get to the field, because yes, these are textbooks and these are procedures. But when we get to the field, we might need to tweak Most of the, because debriefing takes about 3 to 5 days in some cases. But yeah, we are going to work with time and see. And from what we have here, we can under an hour and a half, we might be able to achieve something meaningful, starting from the introduction, which must not be more than 10 to 15 minutes. There are certain things that during this stage, the team leader introduces the team members. We explain the process which we are going to follow. Then we talk about the highlights that the debriefing is not. I'll talk about the highlights of the debriefing, and we let them know that we are not investigating. We are there to help, to render emotional support for them, psychological support, and all that. So we are not investigating. It's a debriefing session to take them through or walk with them through some of their experiences which they've been going through. So during this stage, the team leader would allay the fears of the members. We'll go through the rules of the debriefing. We encourage participation. Then we leave room for answers and questions, and then we announce the procedure as it goes. That's for the first stage, which is introduction stage. That can be done under 10 to 15 minutes, and it depends on the size of the members of the group. That could be done between 10 to 15 members, asking their names, what they do, very, very, very significant, because there we have doctors, we have nurses, we have laboratory scientists, the support staff, the cleaners and all that, they're all involved. So we work with them at various levels. Then the second stage is the fact phase. This could be between 5 to 25 minutes. The fact stage, there are a lot of
I can't hear you again, sir.
Doctor, you're on mute.
Hello?
Okay, can hear you now.
Was it just a break or since?
No,
Was
audio.
it just a break now?
Just a few seconds. Just a few seconds ago.
Okay, I'm back online.
Okay.
So, like I talked, I've moved from the first phase, introduction phase, to the fact phase. The fact phase there addresses how the participants describe their traumatic experiences from their own perspective. And the team should try and give everyone an opportunity to make contribution in an orderly way. Because, you know, in a group, some people are very domineering and dominating. They want to take over the group by sharing their own experiences. Why? Hello? Hello?
Hi.
You are
okay.
Continue.
Okay, sir. So like I said, the group is, the dynamics of the group, you have to take that into consideration too. Because some members might decide to dominate the group by only sharing their own experiences and interjecting and all that. So as the team lead, you should be able to make sure that everybody have opportunities. You encourage people to talk. Some may refuse to speak, or because of the time constraints, some may not even be afforded the opportunity to speak. But you should make sure that everybody participates to express their feelings. And at times, when the participants in the debate are asked to describe their situation, they might bring up emotional faces there. You allow it to vent. And if this happens during this phase, the team should not probe. Because if you probe, it might take long time spending, might virtually spend a long time with only one person. And at times, so the best thing is to eventually ask from the beginning that how are their experiences been? If anybody has some things they want to talk, if people are expressing this, could they raise up their hands? So if about 3 or 4 or 5 people out of 10, for example, or 6 raise up their hand, it gives you a direction how to go. So you address those emotional issues, you acknowledge them, you validate it, and also prepare their mind, because by the time you move into the teaching stage, you'll be able to clear that. So there, you must make sure that you identify their facts, they express their own feelings from their perspective. And one thing, part of the key thing is you don't take notes. Notes must not be taken as they are talking. They're not taking on. So you should be able to assimilate, pick all those things that say so that you'll be able to draw issues out when you get to teaching area. So the third phase talks about the cognitive. That is between, you can spend about 5 to 25 minutes there discussing their thoughts that are associated with the event. This phase represents a transitional phase from the cognitive domain to the emotional domain. And it is intended to allow the participant to shift from description of their cognitive views to their emotional reaction, how they are able to react to their experiences. So this phase begins when the team leader asks the participant to state their first thoughts or the most prominent thing that is on their mind, which is a factor. So those are things that it comes out in their thought, and those will be noticed, will be noted as well. And you look at the first stage, which is the reaction phase, which could take between 10 to 40 minutes. You discuss the feelings that were associated with the event. This phase sets out to allow the participant to identify the most traumatic aspects of this incident for them and the associated emotions, reaction to the trauma. Some of them have watched people die there. They've watched people go from mild to moderate to severe conditions, which has been traumatic for them, seeing people go through that phase and probably bringing their own emotional state out in terms of sympathizing with some of these patients. And that is one of the key things which affect emotions. Once you start sympathizing, it clouds your thoughts, it clouds your emotions, it clouds your judgment. So definitely you are supposed to, you find yourself tilting negatively to the patient's side rather than being empathetic and dealing with issues. You sympathize with the patient. And yes, we are all human beings, definitely. And most of them are not mental health workers, like some of us who have all this information and can deal with that aspect. So those are some of the things we are going to bring to the fore to make them to see that, yes, they should be able to delineate between empathy and sympathy, which is a germane thing in our own practice. So during this phase, most of the talk is done by the participants as well. You allow them to express their feelings, they discuss freely, and without persons being given the opportunity to speak, to allow everybody to air their mind, to free their mind, to ventilate how they feel. And orderliness must still be brought into it. Because this is the period where you allow them to vent how they feel, their experiences, their reactions, and not to have to also take into consideration their needs in terms of the equipment and things that they need to protect themselves also will be brought into places. We are not just dealing with normal hospital patients. These are infected patients which endanger their own life. So they also are worried, they are careful, and anxiety also comes into play. Then we look at the symptom phase here, that we want to identify some signs and symptoms of which these people are experiencing. Example, some of them could be depressed, or symptoms of anxiety, for example, worries and all that. So you identify some of these symptoms, and we're able to work with them in terms of when we start talking about dealing with this situation. This phase is initiated when the team asks the participant to describe any cognitive, physical, emotional, or behavioral experiences which they have been encountering since they started dealing with these individuals. So, and those are our major domains that we normally look at their cognitive, thinking pattern, physical issues, emotional issues, and behavioral. Behavioral could be withdrawal. When they start avoiding having contact or going into the wards. And there is something responsible for that. That's a behavioral experience. So it's a gradual withdrawal from supporting or helping the patients. Or you talk about cognitive thoughts, patient feeling that, oh, I even have this already, which some people are even experiencing outside. Some people are now having some psychosomatic feelings that they have things in they have these feelings in their throats. They have this fever and all that, even which we are seeing around us. So that's for the symptom phase. Now we look at the teaching phase. This is where our expertise come in, and it depends on this will be put to play at the field, whereby we provide information about ways to cope with this situation. This phase tends to flow naturally after we've talked about all these symptoms and its goals. We educate the participants about. Yes, Dr. Kajiro?
Yes, how are you?
Okay, sir. Okay, so this phase tends to flow naturally. And the symptom phase, its goal is to educate the participants about critical incidences and stress, and how we're going to manage them and all that. So then we go to the 7th stage, which is the winding up phase, which seeks to talk about termination at this stage, taking them through. This is the final stage of the debriefing. Its goal is to clarify ambiguous issues, we prepare them for termination, and also bring to closure the discussion which has ensued. So by timing, I gave a time difference for all the phases, but it depends on how we are going to work with it when we get to the field, because we don't have all the ample time to spend hours or days. So we will be able to put all these into an hour, 2-hour session. If you want to do anything meaningful, it should be between an hour and a half and 2 hours. Because, for example, if you have 15 members or 15 participants, by the time you allow them to talk, to share their views, talk about venting out their experiences, you talk about expressing their views and all that, it needs time. But we should be able to guide the session so that we can work with time. So that is the last phase of the stages. Thank you very much. Doc?
Yes. I guess we all followed Dr. Ajirotutu. That was a very beautiful presentation. He has
Thank you, sir.
Just given us a full glare of what debriefing is. But
yes,
we all know that debriefing usually occurs after a major traumatic situation. Now, in our own situation now, we might not say we're having a traumatic situation as it's supposed to be. Now, our debriefing process is going to be an abridged one because we are dealing with people that might be experiencing trauma based on the job they're doing, and the job is ongoing, so that we can reduce their level of psychological distress. So, like he mentioned, we're going to be having an expanded theme because we have about 3 or 4 centers. And from our various meetings in EOC, a lot of people are beginning to complain of being burnt out. And they are all looking for our help. This is the time. And we are going to be training. You can see, you are going to assign roles, and we are going to produce our own protocol. This protocol might tap from exactly what he has described to us succinctly, okay? And the essence is for us to go through it. He will be providing us with the slides. We will all go through it and be ready, because any member of this team can be called upon to join the staff welfare or debriefing team, okay? So, but meanwhile, we will start with the first group that will have a little bit of training and harmonize the training protocol before they start going to the field. And we should do that as soon as possible. Once more, the lecture is an eye-opening one for so many of us. And I guess some of us might have questions based on this presentation. Let's take the questions before we go to the next issue we have today. So the floor is open now for questions. Hello? Yes.
Hello, can hear you.
Yeah,
sorry,
so,
the control room should please begin to control. If you see the people that raise their hands, you can call for question, please.
All right, sir. Dr. Fadipe has the question.
Okay, so Dr. Fadipe can go on. Then you mute every other person that is not talking so that we can hear him.
Good morning.
All right, sir.
Good morning, Dr. Ajirotutu. Thank you for the presentation. I was just wondering, considering the fact that there are different categories of staff in the field involved in case management and all that, we need help for us to consider when we are grouping them to consider this, because the experiences will differ. So that's the question that I have.
Dr. Ajirotutu, you can take the question. Hello, Dr. Ajirotutu, are you there? Okay, am I on now?
Can you hear me, sir?
Okay. Yes, Dr.
He's back.
Okay, he's back now. Okay.
Dr. Fadipe raised the question. It stated that are we going to consider the level of the health workers, education, classification, and all that, and categories? And I said we might put that into consideration because we have the core health workers. We can work with them, and we should be able to work with the doctors, nurses, other professionals who are working at the front line in a group. While the cleaners and others, we could have them in another session. I feel we can take that categorization into consideration. The core professionals and the support services also. So we can have two groups because they might not be able to reach them at the same level in terms of discussion. So for the professionals, we can have a same playing ground with them compared to the cleaners, whereby some of them might not be able to communicate properly in English. We might have to come down to speaking vernacular and all that to be able to reach them and interact with them. So that can be considered, sir. Are you satisfied, sir?
Okay.
Yes, thank you very much. Thank you.
So, Dr. Fadipe, do you have another view about that?
No. So that's what I thought too. So it's yes, I just wanted to clarify.
Thank you, sir.
Yes, sir.
Okay.
Okay. Any more questions, please? Dr. Wallaby, any more hands raised? Hello? Hello? Any more hands raised?
Dr. Ipere.
Okay, let me go.
Yes, sir. No more hands raised.
Okay, it's all right. Okay.
Hello, sir. Hello, sir.
Yes.
So I'll make the presentations available today.
Okay.
On that platform, or I'll say that you send it to the other platforms, sir.
Yes.
So they are full presentations, yes. So that they can go through it from the starting to the beginning. Exactly. But when we get to the field, we're just going to extract what we want to work with and yes. Modify it to suit the intervention plan there.
Good. Okay,
sir.
All right. That's what we're going to be doing, because some people, some people might be asking, oh, why are we doing debriefing? This and that. We need to understand why we're doing that. Okay, and there's always timeline when you do debriefing and some of those considerations. But yes, we are adapting it because of what we think the problem is. Okay. and we'll come up with a protocol that will accommodate the needs of the healthcare professionals who are working tirelessly to meet the present need of the situation. All right. Thank you very much for that beautiful presentation. Now, the next thing we have in the agenda is the way forward, taking into consideration the number of cases at our disposal now. Now, if you listen to the EOC meeting of yesterday that Dr. Ajirotutu presented to us, you will notice that it's as if we're beginning to have a backlash. We're not meeting, the issue is we're not meeting up as we should. So, and the problem as it is now, like was highlighted yesterday, was wrong phone numbers and inability of these people to pick up their calls. Now, we have to look at the way forward. How do we meet up the demands of the job in spite of all these difficulties? Is there anything we can do to reach out? Any creative means? What are the options available to us? Because presently, we are going to be having like 70 new cases today. And we have not even finished the data of yesterday. And my guess is like by tomorrow, it's going to be more because the surveillance team is going into aggressive testing. So we should be able to be ready to do same. And once we have any patient assigned to us, we go straight immediately. We don't give it time. Before 1 hour, we have dealt with the case and reported the case report the case as soon as possible. Because we are now entering, they're giving us the spreadsheet to enter so that everybody can be seeing what is happening at the same time. So I don't want our team to be the one pulling them back. So all hands is going to be on deck going forward. Okay, please, I don't know whether anybody has any idea on how we're going to subvert some of these challenges we encounter on the field. Please, I need all your contributions so that we can see how we can deal with it. Thank you. Okay, you can. I can see Dr. Ajirotutu, you can go on. You can go on.
Okay, so thank you, Dr. Ome.
Yes.
Hello.
Yes, we're on.
Okay, so yeah, so you brought up a very valid point and concern, and I know that, I mean, if you attend the EOC, you will not be happy when every time it looks like the psychosocial team is the one drawing them, the other members of the group back. But I don't think that it is fair because right from the scratch, if you remember, I would always agree that much that why is it that from the beginning you can't let, not everybody working in the team needs to have access to some of this information, but why can you not make it such that everybody has access to this information real time? So you suspect somebody, you are taking sample, you are logging it in, as the result is being uploaded. Why is it not possible that someone in the psychosocial team is getting that feedback? That is one. So I realized that even between the surveillance and the lab, even surveillance has to struggle. So they always have to go back to go and start shopping for the phone numbers for these various individuals. So I don't think that it is us that should be then take the blame. That's one. Two is how then do we move forward? So for instance, I was having a discussion with Dr. Adebayo, and she was saying that whatever because I think she communicates with Dr. Oshodi, and that the tracking sheets that we use, if we can share it with her, so that same tracking sheet we share with her, once she gets the information of these the patients, she will upload it on our own tracking sheet and put a timestamp to it. and then we will take it from there. That is one way. The other way is that we have a tracking sheet. If we decide to go the way that it's been going, that she feeds us. When the surveillance team feeds us, we also have to be able to track it, to say that, okay, because Dr. Chodi had said that between 8 and 12, we should be ready today, for instance, to make the calls. But as I speak, I don't know, except maybe the numbers and the names have been assigned to the other group. I haven't received any such names or numbers. And that suggests that maybe it hasn't been sent to her. And by the time we get to the EOC today, they will say that there's a backlog of 70. Psychosocial, what is happening? Yeah. Meanwhile, we haven't received this. So we also then maybe need to begin to be proactive in saying, okay, well, we received 70 names at 1 p.m. today. Between 1 p.m. and 3 p.m., we were able to call 35 people. But 35, the remaining 35, we had called at maybe this 2 different times, 3 different times. The number was not ringing. The number was ringing, they didn't pick, or it was another person that picked the phone. And then the other thing that we need to consider is, if, for instance, the number is connecting, but the person is not picking, is it okay to then send a generic text to say, okay, well, we understand that you had introduced ourselves, say that we know that you had this swabs taken on so day. Can you please contact me on this number with regards to your results?
All right.
So these are some of the things that we need to look into. And maybe as the numbers are increasing, then we may need more hands need to be on deck clearly, so that we can get this get it over with on time.
It's all right.
Thank you. Here?
Okay. Is that Dr.
So there are 2 things.
Yes,
so it is right? Now almost. Yes, sir. Good morning. It is, or good afternoon. It is now 1 p.m. Let me call it 1 p.m. We do not have a list. Okay. What happens sometimes, we get a list and we start getting names piecemeal over the day. So they'll say they've sent a list. You've sent me a list of names with no contact details. Exactly. And then I start to get the contact details piecemeal. It's not a database, it is piecemeal. And let's not forget that our role, it is psychosocial support. So it's not a question of, I get a name and then I'm literally just telling the person, you're positive, goodbye, move on. Sometimes you're calling people 2, 3 times, they are in denial, they drop the phone, you call back again, you speak to their father, the mother, the next door neighbor. So I want us to be very careful that we don't take the flack or slack for failure of other platforms. Evacuation team, and we're getting, as far as late as 8 p.m., I'm getting names. Even if I deploy those names at night, I have to be fair to the volunteers. They will sleep. So they're not always on their phones waiting. And there are internet issues. I mean, I just want us to manage expectations so we're not slowing things down. And then when they say they gave us 32 names, of those 32, 16 had numbers. Of 16, 5 numbers were error, unavailable, ringing, whatever, they were unavailable. Our disclosure rate, therefore, was 100% or 70%, depending on what you want to use. We got 16 names with numbers. We called all 16. We're now tagging the times. I've started tagging as of yesterday for each call, what time the volunteer actually called. Yes. And we are recording 80, 90, 100% disclosure rates, at least over 80 on what we have. We need to be careful that nobody puts us in a corner and says we are at fault. If you have not shared names at 1 o'clock, there is nothing, because those names have to be checked against the database because they send us duplicates. So you have to go through all the names you've received, make sure it's not a duplicate, clean it out, assign it, anonymize it appropriately. And they're not sending us databases, they're sending us names one by one. Good. So I want us to be careful that when we argue back, we're not put in a position where we are taking the responsibility for the failure of evacuation and the failure of surveillance. because that's their failure. I'm
All
just
right.
saying. From today, we are reporting disclosure rates.
All right.
Moving
Thank
forward.
you very much
Yes.
for that contribution. Has anybody any more thing before I'll tell you what the situation is now? Any more suggestion?
Dr. Omer, let me just add to so that's pretty much, and that's the problem. So it's a problem with the database, because clearly even the surveillance team doesn't have the result. The database that laboratory has doesn't have phone numbers.
Good.
So when surveillance gets the positives from laboratory, they then have to begin to shop for phone numbers. So I think maybe at the EOC, we need to make this clear. And maybe Dr. Shodi needs to know, since she's attending today's meeting, that she needs to present that clearly as a challenge. And I think that I like the idea of what, because clearly now from what she's saying, I mean, 90, 100%, then it's not really our fault. You didn't send me the number. And then even the evacuation team have, because as at Saturday, in my presence, the person in surveillance was telling the evacuation team lead that there were 3 people that we had contacted, and this was at about 8 p.m. that were waiting evacuation. So they will come the next day and say that there are 60 people waiting for evacuation, without knowing that, oh, it's not really, we have done our own part. So I think that maybe some of these things should be included as part of the challenges, and maybe based on that recommendations. Thank you.
All right. Thank you very much. Your points are all we're taking, and they are in sync with what we're doing. Now, what I want to reassure everybody is that we're not going to take the fall for other people's mistake or laxities. Now, I can tell you, in the few days back, we have been having a lot of battle trying to sort out some of these things. And what we've come to realize is that there is a kind of division in the surveillance team. Okay, we have another group on the field sending us information. Then those ones are sending to me disjointed information, and another one sending to Bisola, coming from Bisola, and they are not interacting. So it has been causing a lot of problems. Now let us go back to the protocol that everybody shared. When the lab made their presentation, the result comes from the lab. Now, the positive results go to psychosocial. The negative result goes to case management for disclosures. Now, from the psychosocial, after disclosing, we inform the evacuation team. That is what it was supposed to be. But it looks like the surveillance team is fractionalized or disjointed. So the information that is supposed to be coming to us through them is coming from different sources, and it is not harmonized. And that is causing a lot of problem. I had to interact differently with Dr. Nosanya, who is on the field, and Dr. Adebayo, okay, who is collecting. So most of the information Dr. Nosanya sent to me, Dr. Adebayo did not know. So I have to, after interacting with Dr. Shodi, I have to send information back to Nosanya to tell her to send those information to Dr. Adebayo, who in turn sent to us. So when they send to us, we'll deal and then send to evacuation, so that there will be a continuous flow and the directional flow of that information, so that it will not be disjointed. So, but they are not doing that yet, and we're not going to take a fault for that. For instance, these 70 patients we have not gotten yet. Now we are expecting it to come from Dr. Adebayo. If it comes from Dr. Adebayo, then we'll deal. And there's also another issue which Dr. Fashanu raised now, which has been tearing us apart. Most of the information they are sending to us has no contact, no phone number. It's not only that they do not have phone number, the ones that have phone number assigned to them are wrong phone numbers. So these are the issues we are seeing. So how are we going to deal with that? Remember, the people that collect sample are the ones that should be collecting all this information. That means we are going to take it back to them. Those people that are collecting samples, they are not documenting properly. I think that is where the problem lies. If they document properly, I can give you one example of one case I had to deal with. I called the man. The man's name, the man is an Igbo man. But when I called the man, the number they gave me, the name that appeared from Truecaller is a Yoruba name. And the man picked the call and was pretending as if he was distressed. When I finished talking for about 5 minutes with grunt, okay, that was all I had from him. Then he used another number to call me. Then who gave me that number I called now? I had to start explaining what were. He said, well, he is hell and hearty. He is not in any admission that he is so and so person, that he doesn't know how somebody could be calling him when he's well. Okay, and how his number got to our center. So many people have reported similar cases. So how do we meet their target, in quotes, if we have all these problems coming from them? Now, I think we are going to articulate some of these problems. Dr. Oshodi will be going to the meeting today, and he's going to present it, whether they ask for it or not. He's going to bring it up, because this is the problem bedeviling our services, and we have to bring it to be. It doesn't matter whose ox is God, okay? We can't be taking the fall for another person's what inefficiency. So I think we bring out some of these things, articulate it, and push it out there today, okay? That will make our job a lot better. And also the issue of the calls we have been making, and without something like top up, only very few persons has their phone. And we still have so many other persons using their money, using their phone to make all these calls. We have been on their neck, okay? And the IM is still insisting that he has to get approval from the PS before they give us something. But I pressurized him so much the other day that he said he has little money, but I can get Dr. Oshodi's account so that he can see what he can do. But I've not really followed that. Today, I'll try and reach him and ask him how far, okay, and see how we can attend to some of these problems, okay? That is just a brief information about going forward. I don't know whether anybody has anything to say.
Hello, Dr. May?
Yes.
Hello?
Yes, I'm on. I can hear you.
Okay, is Ajirotutu on the line?
Okay, okay. Yeah.
Yesterday I was at the EOC. It was a serious issue.
Yes.
And that is the major problem is that they keep passing the buck. Yes. And the problem actually is from laboratory.
Yes.
Because it is laboratory that they get to first, or probably surveillance and blah, blah, blah. And like I told them yesterday, the doctor from WHO stood up and said that maybe psychosocial is not reaching out enough. I said, how long would it take us to make 16 calls when we have a team of about 10 people on ground reaching out to people for disclosure? When you send, like Dr. Fasha, they sent a list of 32 names, 16 of them had no numbers. Do you want us to manufacture numbers So if Mr. is not...
Check your audio. You are disconnected.
Sir.
Okay, you're back.
That is not getting feedback from psychosocial as expected. And I said, all the numbers that were given to us is from surveillance. And we were able to reach them. Why would we? Why Fadipe talked about? Immediately the load, everybody sees what is on ground. Yeah. And the only thing we need to do now is to give feedback. Immediately we call, we try 2-3 times, we feedback the load that these calls cannot be reached. It will be reached, it will appear that we have done what we are supposed to do.
Good.
But because in the past we've not been doing that, we just report. That is why they can nail it to us. And definitely we are doing our best. Evacuation just started, it just got more vehicles. He had backlog. He had backlog before.
Yes.
So much backlog. Yes. He had backlog before. I could see, we always raising it in our write-ups. That 4 people are still waiting for evacuation, blah, 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 blah. And we get back to him, and they just gave him more vehicles. That is why he's talking about it. So what they agreed on yesterday was that any number that is not going, are you with me?
Yes, go on. Any
number that is not going, or is switched off, you should go and carry them. I wonder how that is going to work. You should just go via home address to go and pick them. That is the agreement they reach. Because some of them are not psychologically minded. Dr. Fashanu just explained the procedure. You're not going to just call somebody, we just did your test and your test is positive. So we are coming to pick you. That sounds unhuman. Or like the way we will go about all the things we are explaining to them, or the way we will go about it to break the news, because they are not psychologically minded. So that is where we are. So any case, any number that we cannot reach, we send it back to them. Then we send it back to the platform, to the dashboard. They see that we have contacted but cannot be reached. We wash our hands off there. Good. They will report the ones that we've seen.
I think they have given us the spreadsheet. I think Dr. Fashinu is...
No, yes, the doctor has it already, and they have started loading it.
Good. That's all.
But now, this 70, I don't know. Hello, sir.
Yes.
Hello, sir.
Good. Go on.
Like these numbers now, like Dr. Fashanu said that they have not gotten this number by 1 o'clock now. Yes. And the meeting is 4 o'clock. So they're just going to give their own numbers and expect us to do miracle.
No, it's not a problem. It's not our problem anymore. Once
I know, I'm just about you.
Once we get there, we log in.
With me, sir.
Yeah.
Okay.
Once we get the list, we log in when we got the list and what we did, whatever. So the person who is going to the meeting today will be able to present all these things the way they are, so that they will see it's not from our side.
Because we are really trying.
Yeah.
Thanks, Doc.
So, any more comments on this before we round up? I think we have spent
Good afternoon, Dr. Ome.
Oh, good afternoon. Dr. Kachero, right?
Olumide Okeowo is my name.
Okay.
Yes. I wanted to also highlight the fact that there are some people I called and they said they've already received negative results. In fact, they're from FMC Ebutemeta, and their medical director actually called me on behalf of those people that they've already contacted them from their isolation center. I don't know which isolation center, and they sent them, because they sent in 14 names and they sent them 13 names negative. So some of the calls that I made, 2 of those names were part of the 13 they sent back to them. So they are saying that, oh, those results that we need to reconfirm and all of that. So we also need to add that to what we're taking back to the surveillance team. Because now it seems as if they are now confusing some of the information they are meant to give to our team, or the one for case management they are giving to us. So that area needs also to be clarified. Thank you.
Okay. So sorry, I don't know. Can I respond?
Okay, go on.
Yes,
Sorry, Mr. Okay, when was this?
This was day before yesterday, and I sent it to Dr. Fashan.
Okay, so
I even sent it as my report on the platform.
Okay, so on Saturday, this. Okay.
Go ahead, please.
Okay, so on Saturday, this issue actually came up. And I think the problem, the way the laboratory presented it, the issue was with the laboratory. Because someone from the WHO brought this issue up. And what the laboratory person said they did was that, so they acknowledged the fact that they communicated one in error, so that the person was actually positive, but they informed him that it was negative. Now, but that there was a second person who was positive, so they had about 2 false negatives.
Okay.
Or false, they had inconclusive results for about 2 of them, so that he deliberately did not release the results of 4 people. But one of the 4 was actually positive, but he had informed that it was negative. So I think it was a mix-up with the laboratory. So why they did not, based on what you are saying now, and that they sent us these results, I'm wondering why they did not accept at that meeting, because clearly they made it look like, oh, it was that maybe it was the people at FMC that didn't hear us clearly. See? But you are now confirming that even you received the results that suggest.
Yes.
Okay, Dr. Fashan, what do you have to say?
Actually, thank you. So the most we can do is document this and escalate it. And we've done that. It was on the slide deck yesterday. I shared it with Dr. Ajirotutu in a report. We have 2 tables. One documents results where there is some dispute over negative, positive. And we document it. We give the names, number, all the relevant information is documented and escalated back to laboratory. So where they're not dealing with on a case-by-case basis, but what we do is we summarize in our daily reports. These were the cases as of today that there were issues around disclosure. Then in the comments, we put these were the issues around disclosure. We shared one yesterday. So I think it's just, and it happens with any system, it's just making sure that we are doing a better job of documenting and communicating. Good. So we've started documenting those cases, and it's just now making sure how we communicate to labs or surveillance. But we've definitely recorded those 2 cases from Ebutemeta that were disputing the results.
All right, that's a good one. You just mentioned what I wanted to say now. Documentation. We must, because that's the only language to understand. Once you have it on paper, okay, and everybody will see it, that's the only language to understand. And we must make sure that any of these things are documented and reported appropriately. The issue he just raised now, he's not alone. I also had one that they sent to me from the field, that the person could not be, did not want to go on admission, that I should talk to the person to go on admission. I now talked to the person and got the person ready to go. I called them to go and pick. They delayed in picking the person without getting back to me. The next morning, the person said called me and said he has been waiting for them to come and pick her. But somebody called her that morning that her result is negative, that it was an error. Then I have to start calling, only to discover that the person was never positive. And somebody communicated, and the worst thing was that the person's madam called me after all these things, and she became hysterical. Mobe, you know how these psychedelic ladies are, that the housemaid has killed her and all those things. So I had to go doing debriefing after the news was this thing. due to somebody's error. Yesterday, again, somebody that has been in admission, being positive, somebody called him, I think from Naima, that he was never positive, that his result was negative. And that's what we're still working on up to now. So there's a lot of mistakes flying all over the corner, and we don't know where that is coming from. And that is exactly what we're going to be documenting. Let them keep passing the buck, but if we document it, we can always have evidence to prove that we noted this, we noted this. If they like, let them respond to it, or they keep passing buck. So it's important, Dr. Fashion mentioned it now. Please, we must document. Any case you see that is crooked, please escalate it, document it, and let's have evidence so that when we get to EOC, we can prove to them that we have been doing what we're supposed to do. Okay? Thank you very much. So, any other business of the day? AOB now.
Okay, so Mr. Ayodeji still has a question. Mr. Ayodeji Ajayi.
Okay, let him go on. Are you on? Go ahead.
Okay, thank you very much. Good afternoon, everybody. I have a major concern, and that has to do with the evacuation of the patients we call. On several occasions, we call those patients. A patient I called since yesterday morning around 10 a.m. This morning, she called me back. Then I think the HR of the hospital also called back around 10 o'clock that they've not come to evacuate her. And you know the way these things are. Some of them are usually panicky, they are disenchanted, and they want to get to the treatment center as soon as possible, especially for those who believe in the treatments. So I think there should be a timeline for all these things, so we don't keep them waiting endlessly. I called another person yesterday. The person waited till evening. He had to drive himself down there. So all these issues between our call and evacuation, I think it has to be seamless so that we don't keep getting calls back from the patients. Thank you.
That's a good point you just raised. We have been dealing with this for a very long time. But I think evacuation has more vehicles now. Okay? So we're going to be letting them know. But they have refused to tell us the time between preparing these people and picking up. Because if they were able to tell us, once we call them, we should expect them to be there in the next 2 or 3 hours. That will make the job a lot more seamless, like you said. But they are not doing that yet. What I'm going to do now is I will talk to Mr. Anibaba. I'll let him know what the situation is so that it wouldn't be only from us. Okay. If we let him know what the situation is, let's know what they're going to say and how prepared they are to pick up the patients we have prepared. Okay. I don't know if any other person has any way forward.
Hello, Dr. Charles.
Yes.
Hello. Hello, sir.
Yes, I can hear you. Go on,
okay,
go on.
Sir. You just raised a point now, and I think we should have one person working with Anibaba. My suggestion.
Okay. Yes.
Like you just said, one person working with him who would relay. Because yesterday they asked him that how many vehicles does he have? They said he has 9 ambulances now. He has 9. And they asked him that how many trips can he make a day, each ambulance?
Yes.
They gave him a target of 5 per day. The roads are free.
For each?
Yes. Because they told him that he should put each vehicle at designated to each local government.
Okay. Are you still there?
Sir.
Okay, go on.
That they should decentralize by putting vehicles at each local government for easy movement.
Yes.
He wasn't comfortable with that. Wasn't comfortable with that. I don't know, but they told him that the target they gave him yesterday, that from yesterday night, we should start moving people in.
Okay.
And as at now, once we, like these numbers now that we have not gotten now, I think we should just pull you, sir, should pull a call through to Dr. Oshodi.
Okay.
And tell her to tell IM now that we don't have the numbers now at 120.
Yeah.
Or is it time is 130 now?
Yeah.
We are taking these responsibilities now. And there's no more turning back. So we just pull a call because she's in a meeting with them now. And she should notify them there and then that we have not received the numbers
Okay.
that have been announced outside. And that's what they expect us to start doing something now. So that's it, sir.
All right. We'll take all that into consideration and see.
Okay, sir. So we should communicate with Dr. Shodi right now. So the meeting so that she can raise it there.
It's okay. So okay, any more issues before we end this meeting?
Super.
All right. In the absence of any other issue, I thank you all for making time to join this meeting. Please let us still remain the person we are and keep doing the best we can. Thank you very much.
Yeah, thanks for the presentation and the meeting, sir.
Dr. Fash.
Thank you very much.
Yes,
well done,
sir. Yes, thank you.
Thank you all.
Thank you.
Thank you, sir. Thank you all.
I think they are now sharing the more information on the Google thing. But what I may ask, please, can all the volunteers try as much as possible to respond within the hour?
Doc. Hello, Dr. Fashanu. Hello. Hello.
Sorry, Ma, we didn't get that.
Hello.
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 Yes, hello. Hello. Hello.
Hello.
Dr. Fadipe. Hello.
Okay, so is Dr. Fashanu back?
No, hello.
Yes, I'm here.
Okay. Dr. Fadipe.
Yes.
As
well.
God bless you, bro. I think the line has been cut off.
Okay, all right, no problem.
Fantastic day.
Yeah, you too. Have a nice day.
Okay, bro. Okay.